All right, so I guess we didn't
Yeah,
decide. Are you
yeah.
going to do our intro, Sylvie?
Yes, yes. Welcome,
Excellent.
everybody, and to our session, which is basically, I think, a space for us to meet as a healthcare oriented medicine, healthcare oriented special interest group, but also to kind of involve other people who might be interested in this area, whether they want to learn more about it or they're starting a project in a similar topic. And what we're going to do today is just introduce ourselves. We have a panel of wonderful experts here who have experience in healthcare and using QE methods to explore topics in healthcare. And then we're just going to open it up to have a discussion. So we definitely don't want to make anything here formal. It is midnight here in Hungary where I'm at. So if I start not making sense, please let me know by, doing something and letting me know that I'm not making any sense. Anyway, I'd like to introduce you to the panel. We have Andrew Ruiz in Madison. Hi, Andrew. We have Sarah Jung, who's also in Madison. We have Vitali Popov, who is in, oh my gosh, Vitali, Michigan, right? Awesome. And we have Abby Woodridge in, oh God, it's already
Illinois.
starting. Thank you. So why don't you go first, Abby, and start to tell people about your research interests and your experience?
Sure. So as I mentioned yesterday, my area is human factors and ergonomics, my home, my theoretical home. And most of my research focuses on thinking about how we can design systems and technology for healthcare teams that will ultimately end up improving quality of care and patient safety. So, I can run through the statistics. Like, patient safety is a problem, particularly here in the US. We have way too many people dying from preventable medical error in hospitals. Most of us are going to experience a diagnostic error at one point in our life. If we're lucky, it'll just be at one point, and it will not have horrible outcomes. So HFE has emerged as a discipline that can help, because all of those bad things are happening where little holes like you would see in a Swiss cheese slice essentially line up just right for the bad thing to actually happen, rather than getting caught at one layer or another. But we haven't been as successful as we might like for a number of reasons. And I think quantitative ethnography can help. So for me, QE has been really instrumental in providing some of the tools and even philosophical approaches to being able to address problems in healthcare quality and safety. I mentioned them very briefly yesterday. So, for example, being able to understand what's actually happening in the healthcare environment by going out and doing observation and really understanding the experience and perspective of the people who are, doing the work or being in the healthcare setting, if they're patients or family. And that fits really nice with some of the human factors approaches that I use. But then, of course, also the tools we have are really valuable, particularly those that let us quantify qualitative data. So a lot of healthcare providers, administrators, and academics really still skew towards quantitative as the best and the gold standard of evidence is a randomized controlled trial. So having numbers in the mix can really help. It also lets us generalize a bit. The one challenge that I'm kind of having that I would be interested in brainstorming with you all and hearing if you experience it too is how resource intensive these methods are. So to do an ethnography, you have to be there. And ideally, you have to be there for a while, and you have to even have time with your participants to learn from them and talk with them, ideally not just observing them. So it's not just your view as an analyst but you actually understand their meaning in their cultural setting. So for me, that's been really something that's challenging on a number of levels, like just pragmatically carrying out the work, getting the hands. But it also, I think, limits the spread of QE because there's only so many people who know what we're doing and are willing to invest those resources. So I'd be interested to hear what you all, my colleagues, are doing around that, and if we can have a way to do as rich, meaningful work, but perhaps speed it up a little bit.
Excellent. Thank you, Abby. I'm making note of some of the questions and topics that you guys are raising for the group, not just the panel. But for now, let's have Sarah introduce herself just so that we can go on in the panel.
Everybody, like Sylvie said, I'm Sarah Jung. I've met a lot of you, but I'll do a brief intro for those of you I haven't. I'm an assistant professor in the Department of Surgery at the University of Wisconsin. I am not a surgeon. I am an educational psychologist with a focus in learning sciences, and have been there in surgery for a few years now to think about how to apply my skills in research and education design in the design of learning environments in medical education, particularly in surgery and surgical specialties. So a few things that I've been thinking about and working on that involve QE and techniques like ENA. So I did try to organize my thoughts a little bit here, so bear with me. But some work that I started out doing that kind of got me into this field was actually with my husband, Kisu, who's one of our trauma and acute care surgeons. And we were trying to figure out for our interdisciplinary trauma teams, particularly our residents and nurses in training, and this kind of relates back to Abby's point, right? How are they engaging in this trauma disposition? And were there any errors that were occurring due to communication, for example? So just briefly, right, when you come into the trauma bay, essentially the team of nurses and surgeons or emergency medicine residents for us should be able to figure out within 10 minutes, like, how do I help this patient? And then where do they need to go? To the CT scanner, to surgery. And it's very complex, and we didn't really have a good way to sort of model that complexity and try to capture what was happening in this situation. And so that was kind of our first foray into QE and using ENA. And I've kind of expanded from there to think about how we might use these methods to look at learner trajectories. So we have a lot of focus on competency-based education right now, and trying to understand how our trainees move from novice to expert, and what does that even really look like. And then an area that I'm interested in is our continuing medical education. So interestingly, CME is not as organized as one might think it is. Like, once you graduate as a physician or a surgeon or whatever, you need to keep up with your training, but the ways that you do that are kind of varied, and there's not a whole lot of evidence as to the effectiveness of many of them. And so CME in many fields, surgery included, is starting to switch to more of a longitudinal, individualized model, utilizing people such as coaches and mentors. But again, we don't really have a good understanding of how to do that and what really makes these relationships effective. And so I think this is another area where what we're doing here applies. I have a lot of questions, honestly, and I'll I'll limit it to one for now, and maybe we can get to some of the others. But a challenge that I have is trying to figure out how to move, using these techniques to understand these complex environments, to using them to help others understand these environments and make recommendations for practice change. And I know it's come up a little bit at the conference already, but that's when I talk to physicians and other practitioners and students, trainees, a lot of it is like, oh, this is interesting, but what does this mean for my day-to-day practice, right? And how will this help me to either improve my patient outcomes, or I think another area where this might have implications is, wellness, burnout, right? What are systems that are contributing to that for our physicians? So anyway, I'll stop there, but those are the things I've been thinking about.
These are awesome questions, Sarah. Yeah, definitely. We will get to talk about this. I think that's at the crux of a lot of our experiences and the things that we're working on as well. Vitali, would you like to continue?
Sure. I don't think I have a choice. Yeah, a little bit of background. So I did my PhD on computer-supported collaborative learning, which is another kind of society, CSEL, and it's very close to ICQE and LUC and ICLS, so the learning sciences, the learning analytics, CSEL, all these brothers or sisters under one family, and ICQU definitely is a close sibling to this, society. So for me, it wasn't kind of mind-blowing or shocking kind of to really see the benefits and affordances of QE philosophy and the methods. So yeah, and then of course I did a lot of research in the K-12 higher education, engineering education, and only in the last 2 years I transitioned into the medical education. So which is fascinating because CSEL, the last 2 letters, it's collaborative learning. So it's a teamwork basically. And as you know, that the past, the present, and the future of medicine, of course, is inherently team-based care. So for me, of course, it was an amazing kind of opportunity to study teams in such a setting that not only kind of they collaborate to learn, but also collaborate to perform. But of course, they're not mutually exclusive. One could become as a collateral skills. If you're learning something, you can also learn how to collaborate, and the other way around. But also, the stakes are much higher because we know that the good teamwork saves lives. When I worked, of course, in K-12 higher education, you learn something didn't work out, it was fine. But here, indeed, we know that good teamwork saves lives, and how can we learn about the processes, and how can we make it better for patients, for clinicians, for everybody's involved. And I was very much surprised when I started kind of learning more about the medical field, that a lot of kind of measurement is based on observational specific skills or global team performance. So they're treating them, assessing them as a static construct, whether it's in a simulation world or in a world, in a real clinical setting. Let's say the simulation runs for like 10, 15 minutes, and then at the end, like overall, your situational awareness was, 5 out of 5-point scale, or your leadership qualities, fantastic. So, but for me, those concepts, absolutely, they are dynamic, interdependent, and multimodal. So dynamic, obviously, for example, trust. You can't just say, okay, after 2 hours of surgery, you trust. Again, excellent. That could be kind of fluctuating. You might lose trust at some point. Let's say I ask for my, let's say I'm a main surgeon and ask some question from a resident. He didn't answer. So you see my trust a little bit kind of lowered it, but then that resident can regain the trust. So I'm saying that it's very dynamic. The same, the cognitive load, it can have some peaks and lows. The same way, it's also very interdependent. We can't really treat our measurements kind of separate. Again, taking this example of attending and a resident surgeon diet, absolutely, they're very interdependent. You have to look at them and measure them in that interdependence. And there are, of course, statistical models to get at this interdependency. And multimodal, obviously, there are so many channels, the way we look, how we feel, what we say, what we do. You can't just look at one modality and say, what they say, that's exactly what it means. So, and I think ENA is very nice positioned to really get at this 3 dimensions, 3 complexities in at least studying team-based training or team-based care. That's it.
Wonderful. And that's definitely something I want to come back to, the ability of ENA to model complexity and maybe some things that are left out. We'll talk a little bit about that, hopefully. Andrew?
Hi, everyone. I'm Andrew Roos. I'm at the University of Wisconsin-Madison at the Systemic Analytics Lab. Essentially, my interest in healthcare came from a few different places. So I actually have a PhD in history, and my specialty was history of medicine and public health. And so I spent all of my graduate training studying medical epistemology and various sort of public health questions, social determinants of health. I did a lot of work on public health nutrition, and sort of out of that really grew a lot of interest in how a kind of both a sort of longer view on the sort of evolution of medicine and public health practices, and thought, but also a sort of more complex view on it really had the potential to influence the practice of medicine itself. And one of the things that I've really been struggling with and sort of starting to do projects that are more on contemporary topics is thinking about, how as a researcher who thinks about those sorts of issues, how to sort of connect that to the kind of day-to-day practice. And I think that challenge is manifold. So on a really basic level, it is like a sort of funding issue, right? There's plenty of funding for basic science in medicine when it's, cell biology or, studying cancer metastasis or whatever it is. There's basically no money, as far as I can tell, for basic science on collaboration, social interaction, patient-physician communication, things like that, right? And so, one of the real challenges in QE is that, we can't just sort of build some system. This is sort of piggybacking on what Abby was talking about yesterday. You can't just sort of build some system and make things better in sort of one shot. It takes a lot of sort of ground building and a lot of time spent getting to know and understand the problems and the people and the interactions, and then figuring out how to model those or abstract some of the key pieces, and then circling back to work with those people to figure things out. And none of that is going to happen under one sort of grant or one kind of funding mechanism. And so I think that's a real challenge, is that I've been able to do kind of cool studies, but getting sort of any momentum around them is really tough. And I think the sort of second piece where I think there's a real opportunity here is in the ability of something like QE to create sort of high fidelity representations of extremely complex interactions that have the ability to actually help both patients and physicians get a better outcome, right? And I say both of them get a better outcome because ultimately the outcomes matter to both of them. They might matter in different ways, but I think a lot of the challenges are that, we have to figure out how to connect the kinds of things that we can do sort of with the pathways that actually lead to those changes in practice. So I really enjoyed listening to Abby talk about that yesterday, but I think also this group could have a really great conversation around sort of how we move away from just being able to do some of that foundational work, the sort of proof of concept kinds of work, and the kind of core research that says like, yeah, there's something here, and actually make the jump to being able to take that and actually build it to something that'll go all the way to the stage of affecting clinical practice, affecting interactivity, either between clinicians or between clinicians and patients. And so I think that's a lot of the stuff that I've been thinking about, and I've partly been thinking about that because I've been trying to start this project on shared decision making and thinking about how to model shared decision making. Abby and Vitali and Sarah and I and Silvia have all talked about this in various points, and I'm not the only one who's sort of thinking about these kinds of problems. But it's been really hard to kind of get funders interested because it doesn't fit real neatly in a lot of the funding mechanisms. And even when it does, the reviewers, it's going to review panels of people that don't do that. And so even when there are specific funding mechanisms, it's very hard to work on. And so I think that's been a real challenge for me to kind of think about how really what this is a way to build a program around something, but there aren't really good mechanisms for that. And so I think that's something I've been really struggling with and trying to figure out how to do it. Yeah, exactly. Which I always include because I know they're going to want it. And it's mostly creative bullshit, but still. But yeah, so I'll stop there. But I think that's actually a real challenge for people that want to do work, and it's even worse in public health, to be perfectly honest, because public health is already underfunded, and so I think there's real challenges in like the practicalities of how to do this work, on top of the fact that this is hard to do in general, and it's hard in part because what we're trying to do is so much more ambitious than create a better rating scale or come up with a better survey, and not that those things don't have any value, but they're very limited in what they can do. And so I think like, we have all this ambition, and I think that's a real challenge, is to get other people excited about that, but also figure out how to actually implement it in a meaningful way.
Excellent, thank you. And this is something that Jamie has actually brought into a discussion earlier, wondering about how to actually communicate what QE is, so sort of how to sell QE to various audiences. And of course, you're going to be thinking about it in different ways if you're trying to sell it to someone who actually works in healthcare, or to a funder, a potential funder. And that's definitely something that we should talk about. I'll also say a few words about myself. I'm Silvia Zorge, or Zorgo, however you want to say it. I'm an assistant professor at Semmelweis University at the Institute of Behavioral Sciences. This is in Budapest, Hungary, in Europe. And I have been mainly focused on how patients make decisions regarding healthcare issues, mainly how they choose therapy for themselves. So once they're diagnosed with an illness, or even before that, when they're just suffering from complaints, how do they search for information? How do they consume information? How do they interpret what they find? And how does all that kind of influence and have an interplay with the decisions that they make? I'm very interested in how worldview and your previous assumptions have an effect on the way that you interpret new information. Right now, I've started the project itself we've started a couple of years ago, but now I've actually gotten my research group to use ENA to kind of do a secondary analysis on some of the qualitative data that we've gathered. And this is in a different topic. This is medical communication in pediatric oncology. So it's basically the situation where a physician has to tell the parents of a child that that child is going to die. And it's not just that the prognosis is terminal, but also that there's no chance for a curative treatment anymore. So all they can do is basically ease symptoms and help the child prepare for death. And so that's, I think it's one of the hardest conversations on both ends. So, I mean, of course, from the parents' side, it's horrible, but also from a physician's side, you don't really get a lot of instructions on how to do that, right? And so even if you have a course on medical communication when you're in medical school, which it actually, according to Sarah, that doesn't really happen in the States, which is super strange. And I want to ask about that if I remember it correctly. But so it's not very generally accepted that this is something that they need. And even if they do have a course on medical communication, it's usually a semester, maybe 2 semesters. At our school, it's actually 2 semesters. So it's a lucky situation, but also unlucky because they're in second year when they get this course. And so they practically forget about it or can't imagine how they can implement these things when they hear about it. So this is a topic that we're looking at from the parents' perspective, but also from the physician's perspective, and trying to get a grasp on how can you convey such horrible information effectively and empathetically. And that's something that's maybe unsurprisingly, but I think for me it was surprisingly different from the parents' point of view and from the physician's point of view. So that's what we're trying to model right now. And it's pretty new and I'm excited about it. So I with this thought, I'd like to open it up to everyone, not just on the panel, but in the audience. If you guys have any questions or any favorites from the questions that we've heard from the panelists, please feel free to unmute yourself. Actually, I'd prefer it if everyone were unmuted, if you can, if the living conditions allow, just unmute yourself, because I think it's way too formal if everyone's muted. Sarah, did you want to say something, or were you just the first one to unmute?
Oh, me? I don't know. Maybe I was just excited about the unmuting.
Can you verify for me actually what I said? Because I recalled something that you.
Yeah. So actually, and I'm going to put her on the spot. Sorry, Sarah Larson. But I'm gonna kind of throw this one out to my colleague, Sarah Larson, who works with our medical students and who also has done some really cool work using QE and ENA to look at assessments of medical students. But Sarah, I think I had said something along the lines of, and sorry, it's saying my internet connection is unstable, but along the lines of like, this is something that medical students get, but not necessarily in a very systematic way. And sometimes it's an addition in other courses. And I know that our surgical residents, for example, like don't get as much practice in this as they probably should, because oftentimes they're the ones still in OR closing, doing the suturing while the attending goes and talks to the families.
Yeah, so there are a few, sorry, was someone talking?
No, you were, go ahead.
Okay, cool. So yeah, as Sarah was saying, I am an administrative program manager for medical students in the Department of Surgery at University of Wisconsin. So I'm pretty familiar with their curriculum. There are no specific classes really about communication, as in like semester-long courses. There are like 2-week classes. I think one of our colleagues, I am blanking on her name, Sarah, she does a feeder class with the medical students on communication, but I don't know, that's not a required course. Sorry, say that again.
Oh, is that Amy?
I think
blanking on the
so.
last name. Yeah.
Yeah.
Okay.
Yeah. And then other courses, or there's just lectures on breaking bad news and things of that nature. But otherwise, at least at the University of Wisconsin, not really.
And that's pretty much true for the whole country. Yeah.
That's
Part,
my
from what I've
understanding.
heard.
Even for Canada.
Yeah, I'm at the University of Washington, and we also have sort of it's sort of sprinkled throughout is the idea, but also that some of that is happening in the preclinical years, and you know, people are memorizing, and then to be trying to put in this other stuff that has to do with relationships and communication, and expect them to prioritize that learning when they don't have a place to apply it yet, I think is, I'm not sure it works real well.
Well, I think that, I mean, time is a really important factor in when a person receives that type of training, and it is training. And I think, you know, in my past hats, I used to work with a lot of surgical residents and teaching them microvascular techniques for working in basic science. And you know, I would always strike up the conversation about, you know, what are your interests? What is your career goal? And what are you doing right now? Are you a gen surg? Are you in anesthesiology, et cetera, et cetera? And it was always at the time in which they would come in, it would be about pretty much the end of year 1, beginning of year 2. And they will have had already that training, but it doesn't help them at that time. And even if it's available, are they really ready? Like, is that information useful to them at that time, right?
Yeah.
And it's like, it's the old saying that goes with, like, the more experience you have, the wiser you are. And the easier it is for you to convey and communicate complex ideas and problems. And I mean, it's one of the things that I think we all struggle as we grow and learn more, is how do we take complicated things and make them simple in a way for everybody to understand. And I think I'm sort of segueing into another area here, but I'm just going to go with it anyways.
Go.
We are seeing a huge issue with distrust in science. And a big part of what is throwing paraffin onto the flame with that is that people don't understand science because it's complex. It's difficult to understand, and you know, it can be a little bit intimidating. And so, and it's a large part of it is because we struggle to try to find ways to explain that, even just to the general public. So, and I'm still trying to figure that out too. And I think that, you know, I could probably use a few courses as part of my PhD in scientific communication. I've taken scientific communication courses, and I can say anecdotally that when I took them, I didn't need them at that time. But I need them now. And I don't have them because I already took them, and I don't really remember that information. And even then, I didn't have a chance to ask the questions that I would have wanted to ask now. And so, I don't know. I think that there's a simple way to look at it, but it takes a lot of work to get there. So, yeah. I don't know. What does everybody think?
Yeah, I definitely agree that the curriculum itself is a little bit strange, even if you have these kinds of courses available and the skills are thought to be important that are connected to those courses, they might not be in the right timing. And so it might be defeating the purpose, actually. I wanted to circle back to something that actually Abby mentioned at the very beginning. I really loved the idea of thinking about, is doing QE in these settings really resource expensive, as Abby put it, and is it worth it? And I was just wondering, you know, there's some people who are embarking on such projects, as Jamie is, and there's some people who have completed maybe multiple projects. Was it resource expensive, and was it worth it in your cases?
Well, just real quickly,
Mhm.
QE is seen, I mean, I'm approaching it from the perspective of, well, I'm already going to have all this data, so why not go the extra step and do the quantitative or work with quantitative ethnography and the tools of QE to apply to the data that I already have. So
yeah, I should have been
and
more
from that
specific.
perspective, it doesn't feel like it's resource intense. It may not feel that way until I'm actually in it, but that's just very quickly.
Yeah,
So
that's interesting because, yeah, I'm sorry, Abby, just a little point of clarification. For me, actually quantifying and going that extra mile with QE it might be the resource expensive. But what did you mean, Abby, when you said that?
So for me, I mean all of it. I mean, if you think about quantitative ethnography as having this foundation and you're doing an ethnography or an ethnographic study, and then you're quantifying it. Doing an ethnography takes some resources,
Yeah.
right? Like you have to be there. You have to find the time to interact with those people. I mean, I am of the opinion that just being in the setting you're studying and observing is great, but your data is going to be even richer and thicker if you get to observe and interview or talk with your participants, which then adds another layer of expense. You have to get those people to talk to you. And in a healthcare setting where stress and burnout are chronic and prevalent, that can be really challenging. And then I actually agree with Sylvie to then do a really well done qualitative ethnography and do the work that you need to do a really well done quantitative ethnography. It's resource heavy too, not in just developing those skills yourself or on your research team, but it actually takes time to do it and do it well. As you do it more, yeah, I guess it's a point of diminishing opportunity cost, but there's still opportunity cost there. And this is not saying that's a bad thing. I think it's worth the resources. I absolutely do think it's worth the resources, but I also think that if we want to convince other people to do this, it would be great if we could refine what we do and come up with methods that are like not QE light in a derogatory way, but just you need to do something quick and dirty to understand what's happening, to make a recommendation, then to go back to Andrew's point about to make a real meaningful change. Like here's a quick and dirty way to do it.
Yeah.
I mean, human factors is struggling with this. We're having the same conversations in my HFE groups about, okay, how do we actually do this in a way that is practical for someone other than just academics?
Yeah, and at least, oh.
Sorry, I just wanted to ask one more question from Abby. Why was it worth it for you? So you mentioned that it was worth it. Why?
So it's actually related to Andrew's point. If you don't, and it also ties in with like classic ergonomics theory, which is before you go to redesign a work system, so keep in mind that's any socio-technical setting you're trying to accomplish a goal, you need to understand the current work system and what works and what doesn't work. And if you don't, you could make things worse, or you could propose a change that will not be adopted. So for me, quantitative ethnography is a way, a really solid way for me to develop that understanding of the current situation and what's not working there. And then it builds the relationship with the participants for me to engage them in a participatory design process, which then, as I mentioned yesterday, makes it a lot easier to convince people, yes, this thing that I'm suggesting you do, whether it's this new piece of technology or just stand in a room and talk to each other, novel concept, is a good idea.
Sounds like what you're describing is quality improvement, more or less.
Quality improvement doesn't have the same theoretical rigor and backbone, but a lot of my studies get through IRBs as QI projects.
There it is.
Yeah, so I was just going to say, I actually really like Abby's answer, and I kind of want to build off it a little bit because I think there's actually two ways to think about the resource intensivity side of things. So there's this old joke that probably a lot of you have heard about, during the space race when they wanted to figure out how you could write things in space. And the sort of apocryphal story is that the American government spent millions of dollars figuring out how to pressurize ink capsules and blah blah blah, and develops a space pen. And what did the Russians do? They used a pencil. And the sort of joke, right, is that well, there was already a solution to the problem. You didn't have to go through this heavy R&D process to come up with it. But I think actually there's different ways to look at that, because if you actually want to write in ink, then a pencil is a terrible solution. And this is sort of back to Abby's point about actually understanding, kind of the not only the problem, but also the full dimensionality of it. And so in that sense, QE is really resource intensive, right? For us to actually go and do all of that ground laying work takes time, it takes bodies, it takes money, it takes access. It's extremely resource intensive. But the thing is that, the problems that we're looking at, we're trying to make a resource less intensive solution, right? So I think about, as Vitali mentioned, the assessment problem, right? You have these ways to rate team performance, but they mostly come down to somebody with a clipboard and a rating scale kind of watching and tallying things up and then saying, here's how you did. Well, that is resource intensive. You need an expert. You need someone to be there. They need someone to develop that scale and validate it and blah, 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 blah. But it also doesn't produce a result that's actually all that useful at the end of the day. So in many ways, what QE is saying is if we front load that sort of groundwork, this I think is exactly what human factors is arguing, Abby, if I understand your explanations from today and yesterday, that if you actually do the really heavy lifting at the beginning to really understand the problem, to come up with models that actually capture the salient features and that communicate them well and blah, 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 so on and so forth, then you can actually come up with a much less resource intensive solution to the problem. You could come up with an assessment that doesn't actually require an expert observer to be there in the room, that can take the transcripts and video and whatever else is produced and communicate back to the learner or the coaches or whatever, something really valuable that didn't require that kind of level of intensivity. But it did require that intensivity to produce that model in the first place and to understand the situation and so on. And so I think this is a really interesting question, because on a certain level, this gets to sort of the stuff that I'm struggling with, which is that you have to convince somebody that all of that front-loaded work will pay off when you can't guarantee that it'll pay off. You have to say, look, if you can give me the time and the space and the money to go in and do all this cool stuff, I can produce something at the end that actually will save time and will be better than what you're doing right now. But that's all, you're selling a promise essentially, and that's a lot harder. It's much easier to say I can make this survey and I can give it to 10,000 people, and yeah, sure, only 1,000 of them will do it, but then I'll have 1,000 data points and I can run a few quick statistical models, and it's cheap and easy and fast, and it gives us information and that kind of thing. And so I think that's a real struggle I think that's not just in medicine, but I think it's particularly a challenge in medicine where, as Abby pointed out, access to people is so difficult, and the spaces are very complex, and the problems are very technical often, but they're also socio-technical because they always involve people interacting. And so I from my perspective, that's a kind of key piece of this, and I haven't yet figured out how to make the leap from trying to do some of that foundational work to get to the point where I can really do the work, right? The thing that would produce that solution and then test it. And if I figure it out, I will share the solution with all of you. But
thank you.
I want to make a space pen, right? I actually think there's good reasons to make a space pen, but it does require all that upfront work.
Andrew, sorry,
yeah,
Silvia,
go
I
ahead.
just want to say, Andrew, that was very, very much an eloquent way of saying what I've been trying to say and struggling to. So yes, front loading matters.
He has a way of
Well,
words.
yeah,
He's wonderful with
Always
words.
does.
Well, listening to you yesterday, Abby, really helped me to crystallize this. This is not. I've sort of always had this in my head, but I haven't really quite been able to nail down how to frame it. And so your way of talking about human factors has been really helpful to me, because my knowledge of the field was basically all of our previous conversations, and that was it. So it was actually really helpful for me, because I think it's really crystallized that that's a big challenge in QE. There is a huge upfront cost, and the back end payoff could be enormous, but you have to convince somebody to get over that hump in order to get to that point. And I think a lot of us are struggling with that piece of it, regardless of the domain that we work in.
Mm. Yeah. I wanted to come back to something that Vitali mentioned, just because I personally am very interested in what you guys have to say. He mentioned a way of thinking about complexity, and this was it was dynamics, interdependence, right, and multimodality. So if we think about complexity in this way or in any other way, in your experience, in again, this is open for anybody, has ENA or any other QE tool been able to satisfy that need for complexity and been able to kind of deliver in that respect? Or have you encountered some limitations? And if so, where were those limitations?
Can I share something?
Yeah.
So just to sort of give a little bit of background to those who I haven't chatted with during the conference. I came from a school of education, or I was a postdoctoral scholar in a school of education, but now my work is situated in a company that, and particularly in the context of nursing and health education, where I'm tasked with working with a cross-disciplinary team of engineers, of UX designers, people who think about human factors, as Abigail pointed out, marketing needs and sales needs to deliver impactful nursing education solutions. And the sort of the last year I've spent working on a new product, not designing it, but more in terms of sort of understanding how best can we understand or find ways to visualize the complex thinking in virtual reality simulations for nursing education. And one of the things, as I spoke with faculty members who want to use simulations, is that they have all these amazing goals about what they hope that simulations will offer to their students, like critical thinking, teamwork and collaboration, community, opportunities to practice safety, patient care. On the other hand, what they're missing is sort of solid ways to assess that performance and to sort of confidently say that, hey, Sylvie, during the pre-briefing, you showed these sort of, connections to the skills I value for you to have or for the cohort to have, versus Vitali, you made some excellent connections during the simulation, versus Andrew, your discussion during the debriefing is sort of pointing out to these things. So what I did was, after we ran the pilot last year, I sort of instantly gravitated towards QE tools, and particularly ENA, to say that, hey, let's sort of, create some worked examples to model this complex thinking that students are engaging in, and not just students, but teachers also, like, what are they enabling students or facilitating them along those complex thinking processes. So ENA has been very useful for me to sort of model those complex cognitive and social processes that are valued in nursing and health education. Mm-hmm. And I'm just about beginning to scratch the surface. So I see a lot of opportunities to not just model student and teacher engagement, but also going back and saying, hey, what can we add in the tool that can better support the nursing students and faculty goals?
Mm-hmm. Sorry, I was adding to the chat while I was listening to you. It's just, I remember the conversations that I've had with Andrew on his aspirations and reasons for wanting to create a situation where you can have immediate feedback in a situation where doctors are working with patients. Can you talk a little bit about that? Because that's so interesting to me.
Are you talking to me?
Yeah, Andrew.
Yeah. Yeah, well, and this, I think, sort of, again, this to circle back to the stuff that we were talking about, and this idea about like, how do you develop things that people will actually use and will solve the problems they actually have, and that sort of thing, is that, you know, I've always had this sense that, you know, I mean, in an ideal world, we would train physicians better to be better communicators, to you know, have better conversations with their patients, and like Sarah and I have talked about this a ton, and you know, one of the challenges is that, like, sure, if you want to tilt at that particular windmill, it's a great solution, but it's not going to happen, right? Like, you know, like getting any kind of change in a medical school curriculum is like monumentally difficult. So I started thinking, well, like, what would be the next best thing, right? Okay, if we can't train them better, what do we do that would still sort of help physicians and patients have better conversations, especially when the whole point is for them to do something collaboratively? And so I started thinking, like, you know, if you had a really good way to model that conversation, it wouldn't actually be all that hard to develop a system that could do some things in real time, right? Like automated transcription and to a lesser extent automated diarization have gotten a lot better and are continuing to get better, and particularly in contexts where there's only a couple speakers and it's a relatively noise-free environment, you could actually get something close to real-time transcription. And if you had a good model to apply to that, you could get something that's pretty close to real-time feedback. And so, you know, even if it could do simple things like make sure that, you know, physicians, you know, realize how long they've been talking without actually checking in with the patient, or, you know, something that could signal to patients that there are some resources that they, you know, that they might want to check out afterwards or before their next conversation, or ways to, you know, make sure that sort of key things don't get lost in the conversation, so on and so forth, right? You know, that could actually be a really cool thing. Now, again, you know, whether it totally solves the problem or not, I don't know, because I haven't been able to go far enough down the road to find out, right? Because that's just the idea, and as Abby has pointed out, right, you really have to do all this foundational work before you even know if it's the right idea or not. So, you know, the foundational work right now is just try to figure out, could I even model it, right? Could I even identify the stuff that I sort of think would characterize these interactions and that maybe hinder them, and be able to reliably identify them and then go from there. But that's sort of one of the things that I think, you know, again, just back to this question of resource intensivity, figuring all that out and doing like all the work to do the modeling, do all the interviews with physicians and patients and observations of conversations, and all of that is a huge lift. Actually, building that system would seem easy in comparison to all of that, right?
Yeah.
I just, Sylvia, have another comment that Vitali, when he mentioned the dimensions of complexity he thinks about. For me, when I talk about complex socio-technical systems, complexity means that you cannot functionally decompose those systems. The subsystems interact. So quantitative ethnography from that perspective, and ENA specifically, has been so huge because it lets you visualize those interactions and start to quantify them, which is the first step to be able to understand them. So I think it's perfect for complex situations and complexity across the board.
Is anyone?
Sorry,
go ahead, Andrew.
The stuff in the chat really quick, because, you know, Abby pointed out, right, that, like, you know, you have to figure out if things fit in the workflow, and that's the thing. I don't even know if it's the right idea, right? Like, it's just the thing that I'm trying to lure at the end as the sort of bait to do the groundwork, which may of course come up with a completely different solution, or you know, or there may not be a good solution for real time stuff, and it does have to be something else. And just looking at Sue's comment, that yeah, absolutely, that's the problem, is like a human who's an expert in this could do this so easily, right? But getting a human in the room is extremely expensive, and it's just not going to happen. Certainly not in our healthcare system, and probably not even in other ones. Or it would only happen under very, very specific sets of circumstances and that kind of thing. And so, I mean, that's exactly why, like, I think that's a better solution, honestly, but like, as would be, you know, providing actually more effective training. But I'm sort of realistic about the odds of those being scalable, right? And I think that's I think that's a really, it's just a real challenge.
Jamie, go ahead, because we're running out of time, but I definitely want to make sure that you had a chance to say what you wanted to.
I was just gonna echo some of Dave Snowden's work. I'm not sure if anybody is familiar with Dave Snowden. So Dave Snowden has basically sort of figured this out in a way. So
Oh, good.
he's a complexity scientist or complexity thinker, I guess you could say, and you know, he really sort of simplifies it down to say that complexity is understanding how the world interacts and behaves so that we can act in it as actuators, but not necessarily as individuals that are changeable by other people, because you can't change people. You can only change the system in which they exist in, or that, at least that's his theory. And he introduced this concept of the Kinefin framework, which basically is a sense-making framework that sort of helps people realize that not all situations are created equal, but in order for us to understand those different situations, they require different responses to be able to successfully navigate them. And you know, I mean, how often have you seen someone try to handle a difficult situation in an overly simplistic way and then not really be able to do it? And then in the end, they're really confused when it failed and they don't really understand why it failed. And I think that the Kinefin framework really kind of helps describe that. So I recommend checking that out. Basically, it's just 4 domains. His theory, or this framework, is four or 5 domains, I believe. So there's you know, it goes from the simple domain, which is the domain of sort of best practices, problems that are really well understood, and solutions that already exist, and there's evidence out there for those solutions. Solving problems in this domain is pretty simple, and it doesn't require a lot of expertise. These are automated things. Then there's the complicated domain. This is where good practices exist. A lot of tacit knowledge also exists, but you have a general idea of some unknowns, but you have more questions than answers in that space. And then, of course, there it gets more complicated. So there's complex domains, where there are unknown unknowns, like we don't know what we don't know, and you don't really even know the right questions to ask. And I think a lot of us are really in that space when it comes to quantitative ethnography. And even trying to understand those problems requires different experimentation, and you know, the final solution might only be apparent once it's actually only discovered. The chaotic domain is a domain in which information or concepts or ideas or theories or whatever exist in a place that are you can't experiment, you can't study. It's in a a place of chaos. Try a good example to trying to understand January 6th, for example, while it was happening, is just not possible. That moment was in the chaotic domain. We didn't have enough information to really form, you know, evidence-based ideas and understandings about the events that took place. But as time went on, we were able to move that from the chaotic domain into these more complex or complicated domains to try to make sense of what was really happening. And then, of course, actually, one could even argue that that moment in time existed in the domain of disorder, which in the center of the Kinefin framework, you have this just sort of black hole, so to speak. And if you don't know where you are in your research, you're in the domain of disorder. That's basically what Dave Snowden says. And the priority is to try to understand, in the context of your own research and your own problems, about how to move through those domains. And it brings in, that's where the systems thinking approach comes in, is because you have to understand those moving cogs to be able to navigate that framework. So anyways, I don't know. I've been listening to what all of you have been saying, and it really sounds very similar to what his work has sort of, what he spent the last 3 or 4 decades trying to understand himself. And so the framework not only tells us how to approach different problems, but it also shows us the characteristics, and how those characteristics can explain to help us recognize the situation in which we're currently in within each respective domain. So anyways, that's, yeah.
Wonderful. Thank you so much for explaining that. And I think it's going to be useful for a lot of people, and we can check it out in more detail. We have to wrap up the session soon. Feel free to stay, actually. I just wanted to add a few final thoughts. Again, very personal. I'm saying it the way I'm feeling it. It's wonderful to speak to other scholars who are working in QE, and even more so with people who are working in healthcare. At least for me, that's closer to my heart, and I think the things that we encounter are even more similar than in the greater community. And thank you so much, guys, for coming. And I think the wonderful conversation that we had shows that we need to have more conversations. And I hope we will.